Hi everyone, welcome back. Now in this video we are going to talk about high anion gap metabolic acidosis. We are already familiar with this diagram where when the pH is low, that is less than 7.35, it is acidemia, and if the mechanism of this acidemia is loss of bicarb or decrease in bicarb, it is metabolic acidosis. Metabolic acidosis is further classified into three groups depending on anion gap. What is anion gap? We are going to discuss this in a bit. The first category is high anion gap, the second one being normal anion gap, and the third one is low or negative anion gap. So high anion gap, whenever we want to understand high anion gap metabolic acidosis, there are two additional concepts which we should consider, that is delta delta and osmolar gap. We'll talk about it shortly. So the concept of electro neutrality is important in plasma. So in plasma at any given time, the total number of positive charges will be equal to total number of negative charges. And out of the total number of positive charges, in other words cations, sodium makes up a large proportion of this. And in terms of anion, bicarb and chloride make a large proportion of it, and the other cations and other anions are really present in smaller concentrations. Hence we use sodium, bicarb and chloride in calculation for anion gap. Now out of the unmeasured anions, or the so-called other anions, albumin constitutes about 75%. Okay, so coming to formula of anion gap, as we just mentioned, anion gap is equal to major cations minus major anions, so which comes to sodium minus chloride plus bicarb. Now what is corrected anion gap? Now if albumin level is significantly different from normal albumin level, then it is going to mess up the calculation of anion gap, right? Because albumin makes up 75% of unmeasured ions, so in a way it is like the third most contributing anion in calculation of anion gap. So whenever the value is different in plasma as compared to normal, it's going to mess up the calculation. Hence we need to correct the anion gap, and the corrected anion gap is anion gap plus 0.25 times normal minus measured albumin. Coming to osmolar gap, just like anion gap or electroneutrality, here we talk about the major solutes that contribute to plasma or serum osmolarity. So in terms of solutes, the major solutes include sodium, BUN and glucose, and hence as a result we use these three solutes in calculation of osmolarity. And remember, there are many other solutes that are present in plasma, but their quantities are so small that we do not use to calculate osmolarity. And osmolar gap is measured osmolarity minus calculated osmolarity. So when we measure the osmolarity, it's also going to constitute the other solutes that are in small quantity. But in calculated, we just talked about it's mainly these three solutes. Now what are the normal values? For anion gap, it depends on the individual laboratory, but usually it is 8 to 12. Osmolar gap is considered normal if it is less than 10 millimoles per liter. And for sodium, potassium, chloride and bicarb, millimole per liter is equal to milliequivalents per liter. This is just because in calculation for these formulas we need to understand that although we used sodium, potassium, chloride and bicarb in milliequivalents per liters, when we are talking about osmolarity, it is actually measured in millimole per liter. So what are the causes of high anion gap metabolic acidosis? So we can divide this into really logical classification. First is overproduction, right, which means that there is increase production of acids. Second is under excretion, which means that we are not able to excrete acids. The third one is impaired clearance. So between excretion and clearance, the main difference is that when we are talking about excreting, we are talking about kidneys, and we are talking about clearance, we are talking about liver failure. The fourth cause is massive rhabdomyolysis. So this is something that we need to remember, because we see a lot of patients who come in after falls and they have a massive rhabdomyolysis. And then there are some miscellaneous causes like use of penicillin derived antibiotics and pyroglutamic acid. Okay, so let's talk about overproduction, because that is the most commonly encountered type of metabolic acidosis among high anion gap metabolic acidosis, and others we already mentioned about that. So in terms of overproduction, it could be either ketoacidosis or lactic acidosis. Ketoacidosis could be diabetic ketoacidosis, alcoholic ketoacidosis, and starvation ketoacidosis. On the other hand, lactic acidosis could be L-lactic acidosis or D-lactic acidosis. And L-lactic acidosis is the commonly encountered that we see in a lot of patients. It is further classified into type A, which is hypoxic, and type B, which is non-hypoxic. So type A, hypoxic. This is a result of impaired perfusion, and so we'll basically see this in any kind of shock. So septic shock, hypoxemia, hypovolemic shock, and also in mesenteric ischemia. Remember, this is a very important cause, and this is something that is most commonly missed. And type B lactic acidosis results because of impaired carbohydrate metabolism. And the main causes include thiamine deficiency, seizure, which is again very common, some certain medications, of note metformin, propofol, iron, and intoxication like ethylene glycol, propylene glycol, methanol, toluene ingestion. And remember, here we are talking about early, because for late toluene ingestion, we talked about this in normal anion gap metabolic acidosis. So this is a simple mnemonic by which we can remember various causes. It's gold mark. So glycols, 5-oxoproline, L-lactate, D-lactate, methanol, aspirin, renal failure, rhabdomyolysis, and ketoacidosis. Okay, so now let's talk about delta delta. So delta delta helps us to detect the presence of concomitant metabolic disorder in addition to high anion gap metabolic acidosis. So what is delta delta? Delta delta is basically the difference between change in anion gap and change in bicarb. So because it is metabolic acidosis, say this is the normal value of bicarb, and because there is metabolic acidosis, the bicarb value is going to fall, right? So they say that this is the bicarb value in case of high anion gap metabolic acidosis. Okay, now just consider the case that there is additional metabolic acidosis present. So if there is an additional metabolic acidosis present, then that means the bicarb value is going to fall further, and for example, it's going to be somewhere over here. What this means is that delta bicarb, the change in bicarb levels is going to increase, and when the change in bicarb level is going to increase, from this formula we can deduce that delta delta is going to go down. Now the opposite is true for metabolic alkalosis, right? So for example, this is the fall in bicarb after high anion gap metabolic acidosis. If there is concomitant metabolic alkalosis present, that means it is going to raise the value of bicarb to somewhere over here. What this is going to do is this is going to decrease the value of delta bicarb, and when this happens, again using the same formula, the delta delta is going to increase. So this is the diagram which is just a simplified version of whatever we already talked about. So In case of ketoacidosis, we use the normal formula that we talked about, and in case of lactic acidosis, the formula is slightly modified, and we use 0.6 times anion gap. Now, the normal value of this delta delta is -5 to +5. So, if your delta delta is -5 to +5, then it's simple high anion gap metabolic acidosis. If it is less than -5, which means delta delta is low, then there is high anion gap metabolic acidosis plus normal anion gap metabolic acidosis. And if it is more than high, which means delta delta is high, then it means high anion gap metabolic acidosis plus metabolic alkalosis. Osmolar gap. So we already talked about the formula for osmolar gap. It is measured osmolarity minus calculated osmolarity, right? This is useful in unexplained high anion gap metabolic acidosis, in cases of coma, and in cases of suspicion of toxic ingestion. So typical solutes associated with high osmolar gap is ethanol, ethylene glycol, propylene glycol, methanol, and isopropanol. So the properties of solute that will increase the osmolar gap, for that the solute will have to be uncharged and would have to be present in high concentration. But remember, this osmolar gap is neither sensitive nor specific. It may be normal in case of ethylene glycol because of higher molecular weight, and ethylene glycol and methanol are metabolized, so it may be normal if presentation is late. And osmolar gap may be elevated in lactic acidosis, alcoholic ketoacidosis, and diabetic ketoacidosis. So what is the main use? The main use is in cases where detection of these toxic substances is not directly possible. For example, if we are not able to measure directly the value of ethylene glycol, then when the patient presents, we can quickly do a blood gas and see that okay, the osmolar gap is high in case of metabolic acidosis, so this might be some kind of toxic ingestion. So fun fact, during this talk we talked about two drugs that are commonly used in ICU settings. The first one is propofol, that causes type B lactic acidosis, and lorazepam, which causes high osmolar gap because it is diluted in ethylene glycol. These are the references, and thank you so much. Please leave your questions and feedback in the comment section below.